and interesting speakers. Our distinguished international speaker will be joining us for this session. We'll be talking about respiratory care. We're focusing on care from the delivery room and then up to the admission. It's a pleasure now to introduce our moderator, Dr. Samar Zainal. She is a consultant neonatologist at the military hospital in Riyadh. She did her training in McMaster. Also has a master's in quality and also has training in hemodynamics. Please join us, Dr. Samar. Also happy to invite Dr. Mohammed Al-Hakami, consultant neonatologist in the Ministry of Health of Jazan and the lead of the section in Jazan. And I'll leave the floor to you to introduce the speakers.
Assalamu alaikum. Our first speaker that we would like to introduce is Dr. Alok Sharma. He's a consultant neonatologist at Corniche Hospital, Abu Dhabi. Dr. Sharma brings over 2 decades of experience in neonatology and pediatrics. He has been trained in practice across India, Vietnam, and the United Kingdom. He completed his medical degree in pediatrics in India on the topic of meconium aspiration, and later he got trained extensively in neonatal pediatric intensive care at major UK centres, including Aberdeen, London, Exeter, Southampton, Portsmouth, and Leicester. He's also a certified simulation healthcare provider and previously served as a neonatal simulation lead at Southampton, UK, from 2012 to 2017. And over the years, Dr. Sharma has developed international recognized courses in simulation-based training, neonatal airway management, crisis resource management, and human factors. And as the director of the OVE Academy, a nonprofit educational initiative, he has helped in deliver neonatal education programs in the UAE, France, Austria, Germany, Vietnam, India, Kenya, and Nepal. So please join us in welcoming Dr. Alok Sharma.
So I'd like to extend a very big thank you to the Saudi Neonatal Society for inviting me for this today. I am extremely grateful and very humbled to be back in Riyadh after about 26 years. I was last here in 1990, so God bless you all, actually 36 years. So I'm going to talk to you about non-invasive support in the delivery suite. And this is a topic that's quite close to my heart. And the reason for that is most of the guidelines that have been published, which I will show you, talk about application of non-invasive respiratory support with a view to trying to expose preterm, extremely preterm, and I would say the small baby group to pressures that will not be damaging, that will not lead to chronic lung disease. But there is a host of other benefits that you can see by use of non-invasive respiratory support, which basically prevents babies from getting infection besides lung damage and pulmonary hypertension. And these benefits then translate into better outcomes. Now, I think from our perspective, when you look at all the guidelines that are there, we've got European guidelines, we've got consensus guidelines from the States, and we've got guidelines from Canada. And whilst all of them talk about the use of non-invasive respiratory support, we do have some recommendations which also need to be adapted locally. And that is because when we have units that are functioning, we have units that vary from level 1 to level 4, and not everybody has the skill and training to be able to manage babies with non-invasive respiratory support in their setup. Now, it's inevitable that if you work in a smaller unit, level 1, level 2, and you're transferring such babies to a higher level of unit, you probably want to stabilize, intubate, ventilate, because they're going to have a transfer. So we have to be pragmatic about how we apply these guidelines in our local context. And that is really what I'm going to speak to you about today. What do most of the guidelines say? Well, using a PEEP, delivery of CPAP with a pressure of about 6, if the baby is breathing and has spontaneous breathing, under 30 weeks of gestation, varying on the guideline. But for babies who say are not breathing, it talks about the application of IPPV with pressures of 20 to 25. The recommendations come from large meta-analysis that show a decrease in death and BPD in babies who are started on nasal continuous positive airway pressure rather than actually having to intubate and mechanically ventilate those babies. Can I just say that all of these recommendations are really based on studies which have been done in babies 24 weeks and above. And it's very well known now that most of our institutions have moved towards resuscitation at about 22 weeks. I've just been to Iowa, where they're resuscitating babies 21 weeks and above. And clearly, I would like to state that this is a completely different population of babies, and the risk of us using a generalized approach of application of PEEP to this group of babies is not without risk. They can die very quickly. That being said, a real important aspect is for the babies who can benefit, for babies who are, say, 24 weeks and above, what is the best strategy, what is the best approach that we should be adopting to be able to keep these babies on PEEP? And that, I would say, really needs very good quality improvement programs. So we run a PEEP failure program in Southampton, where I previously worked, where it was clearly recognized that for most babies above 25 weeks who are breathing, who are decent sized, where there are steroids given to the mother, where there are no significant risk factors and no kind of backgrounds to suggest this baby's had perinatal hypoxia-ischemia, there is every opportunity to give this baby a start with PEEP. On the other hand, selective approach is also important, because we recognize, and as Dr. Saad will tell us, there is a very high failure rate with PEEP. So the support study showed that 83% of babies at 24 and 25 weeks eventually failed. So whilst we start with PEEP, what we've got to have is we've got to have a backup, a rescue method of being able to give them surfactant. And now we have developed such methodologies which are minimally invasive, which can actually keep babies on CPAP without having to intubate them and give them surfactant. So a summary of the current recommendations really focuses on this spectrum. And this spectrum essentially says that if you're resuscitating extremely preterm babies, it is inevitable that these babies are going to be intubated at birth. Now, if that is the case, you may elect to intubate them and give them surfactant as per your unit protocols, stabilize them, and really what units with very high survival at these gestations show that these babies often stay intubated for 4 to 5 weeks. They need more surfactant, and they have complications outside of the respiratory support, IVH, risk of infection, skin problems, which means that when you extubate them and handle them, they're at higher risk of having problems. But clearly, there is a group of babies at 25 to 32 weeks where we can successfully implement strategies of non-invasive ventilatory support and achieve good outcomes and actually decrease bronchopulmonary dysplasia. And then there are our good 32 to 36 weekers who, you would hope need a little bit of non-invasive respiratory support in transition to the mothers. I was 31 weeks, 1,100 grams. So, I hope, this is a group of babies where we can take them forward without any problems. To understand this, over the next 10 minutes, I'm going to take you through the physiology of non-invasive respiratory support. And what I would like to show you through this is the importance of keeping the PEEP. So my biggest bugbear when I enter the delivery room is we often apply a mask to a baby, and the first thing that some of my fellows will do is they'll take the mask off and start suctioning the baby, and you've lost all your FRC, and you're starting all over again. But in addition to that, when you apply PEEP in the delivery suite, you use an interface and a mask. When you transport in the transport incubator, that's one interface change. You then transport from the transport incubator to the non-invasive respiratory support in the incubator. That's the second interface change. You end up with 3 interface changes. And the key question from our perspective is, we have to quality improve. We have to work towards strategies that look at using a single interface that can uniformly allow delivery of PEEP from birth to admission. That has ergonomic challenges, delivery in a single room where you have all the equipment, where you're not going to move the baby. So units like Columbia have very high success rates with PEEP because the baby is delivered with the mother and stays in that room and never moves off. That's difficult in our setup. So how does physiology help us? So this is just courtesy Dr. Stuart Hooper. This is a rabbit pup. And what you can clearly see is this rabbit pup is not breathing. He's surfactant deficient, and we're not giving any PEEP. So actually, you can see uniformly white lungs. There's absolutely no FRC in this. On the other hand, now you can see a rabbit pup, similarly, who's breathing a little bit. So the airways have started to basically become inflated. But actually, we're giving him no respiratory support and no PEEP. And the problem with giving no PEEP is you're going to have no alveolar recruitment. Now, these are babies, obviously extremely preterm, who may need PEEP and may manage without the need for surfactant. But we may give PEEP and they may have PEEP failure. Now the key question is, if you can support this baby from the start with a good mean airway pressure through non-invasive respiratory support, not break your seal, keep the baby breathing with an open glottis, your chances of success of the strategy increase greatly. So this is the same rabbit who's now breathing, you can see very nicely, with very good respiratory drive, with an open glottis, and you can see really good aeration of the lungs. More importantly, from our perspective, what you have at the level of the alveoli is basically alveolar stability. So these alveoli are not collapsing. Now, the difference in delivery room management, when you look at this strategy, is the fact that if you keep PEEP without changing your interface and maintain that throughout the cycle of respiratory support, whilst you're moving, transporting, and moving these babies to CPAP or whatever you use in your delivery suite, you're likely to have much better PEEP success as compared to babies who are not. And then if they need surfactant, you can use non-invasive surfactant methods which are minimally invasive to be able to give them. What we haven't recognized, and this is probably the most important slide that I will show you of my presentation today, is it's not just about the PEEP we provide. It is really about the stimulation, the breathing of the baby that helps the expansion of the lungs alongside that PEEP that makes your non-invasive respiratory support successful. And really, the larynx has a very big role to play here. So in the early fetal period, babies tend to breathe very minimally. The glottis is reducted, and the function of the glottis at this particular stage is to keep fluid within the lungs. The intention is that fluid allows the lungs to grow. Now, unfortunately, if a baby delivers preterm, his glottis is still immature and is behaving as a splint. Now, not only do you have to bypass that with PEEP, but more importantly, unless he breathes, the glottis is not going to be open. So what you'll find is that if you're trying to provide PEEP to babies who are not breathing, or babies who are breathing ineffectively, it is more likely to be unsuccessful. And I'm just going to show you some videos to kind of exemplify what I mean. So again, this is a rabbit pup. The glottis, as you can see, it's completely closed. And you can see absolutely no lung recruitment. This is a rabbit pup that's being provided PEEP at this particular point, encouraging the rabbit pup to breathe, but you can see no lung recruitment because the glottis is closed. Now, one of the problems with the application of face mask PEEP and PEEP in delivery suite is if you apply the pressure and the mask on the face, it stimulates the trigeminal nerve, which basically causes paradoxical apnea, bradycardia, and inhibits the baby's ability to breathe. Both pain and hypoxia are very big problems in that situation because they inhibit and cause the baby to have apnea. Now, you can imagine that if you're trying to apply a face mask to a non-breathing baby, the natural tendency for most of my junior colleagues is, he's not breathing, the SATs and the heart rate aren't improving, let's press harder. Let's try and get better seal. And actually, we end up compounding the problem. Now, in this slide, just see if it works. So one breath, it's just one breath. And can you see how much the lung expands? So that's all it takes, gentle stimulation with gentle face mask application. That is the key to be able to providing good PEEP with adequate breathing. Again, when you look at lung recruitment in a situation where a baby's breathing, that's the glottis, and we're providing PEEP, but we just cannot bypass the glottis here. So actually, we can't expand the lungs at all. Now, once the baby starts breathing, which is now, the glottis has started opening, and what you can see is you can see good lung recruitment. So my take-home messages over here are a few. It's really important that we, whilst we're providing non-invasive respiratory support, gently stimulate to allow babies to breathe. That helps us. It brings their drive into question. It opens the glottis. More importantly, what is very important is that the face mask be applied gently to the face. Just coming back to this slide, I just want to show you what breathing looks like at this situation. So this is a 32 to 36 weeker that you can see over here. And you can see through the movements of the mouth and the cords the esophagus, and the glottis now coming into view. Can you see the vocal cords moving? So this is a mature baby where the glottis is behaving maturely. It's opening and closing to allow you to be able to provide PEEP. On the other hand, if you look at more immature babies, not only is the glottis much smaller, but the vocal cords rarely move. You can see, especially on the left-hand side, a glottic opening where the cords are very much adducted, now open, but not moving at all, and adducted now. So really, provision of PEEP to this group of babies at 22 to 24 weeks, where you have such a small glottis, has a very high risk of failure. On the other hand, if you provide PEEP to the more mature babies, you're likely to be more successful. Eventually, what we want to enable is circulatory transition, and this circulatory transition is quite key. So once you've inflated the lungs, what you will get is lungs that are fully open with good vascular perfusion, and that will allow a good VP mix to allow you to become normoxic. Your heart rate and saturations will gradually come up, and you will transition. So at about 12 hours of age, once you start seeing ductal flow left to right, it indicates your PVR has come down to a point where the lungs are in good condition to be able to oxygenate. The gentle summary of the physiology is that what we should be doing when we're providing non-invasive respiratory support is encouraging spontaneous breathing, encouraging the baby to breathe and open its glottis, and keeping lung recruitment through appropriate non-invasive respiratory support to allow pulmonary cardio transition. And enabling this means that you should minimize interface changes so that we can provide effective PEEP and keep the PEEP maintained. Once you disconnect, which is a problem, you're really more likely to fail in those circumstances as you move forwards. Having covered the physiology and having given you a brief understanding of how you can actually win when you're providing non-invasive respiratory support in the delivery suite, I'm going to examine some of the evidence and cover two important studies. So we can provide PEEP in delivery suite with a face mask, nasal mask, prongs, or ET nasal PEEP. So that's uninasal intubation of the nostril. We also have different devices, Optiflow, CPAP, BiPAP, non-invasive pulmonary pressure. We have nasal high frequency. And really, from our perspective, my key take-home message at this stage is it's not about the device. It is about the training and how you deliver it that is much more important. And there is no evidence, high-quality evidence, that actually shows using a face mask over using a nasal mask at this particular point is really the game changer. There are some studies which I'm going to talk about which now bring into the fact that if you use a face mask, you stimulate trigeminal nerve reflexes, which causes apnea. So there might be benefits in trying to transition onto it in teams that are well-trained. But actually, when you look at the benefits of Optiflow versus CPAP and BiPAP and NIPPV, there's very little high-quality evidence that one is better than the other. Eventually, what we're trying to do is basically achieve adequate ventilation at the level of the lungs with good recruitment. We're trying to prevent underinflation. We're trying to prevent excessive inflation. Now, the question obviously is, what should we start with? Now, we all know that a self-inflating bag cannot actually develop or deliver any PEEP. So most of the units, at least where I have worked, work with a T-piece resuscitator, which provides sustained PEEP with an appropriate size mask and maintains appropriate recruitment. It's quite interesting. In Iowa, they don't use T-pieces. They actually use the anesthetic flow bag. And they use that in delivery suite as well as using it on the neonatal unit. And they have very good results for management of babies between 25 and 28 weeks and being able to keep them on non-invasive respiratory support. It's quite interesting that I was just reading the literature, and this is an article that was just published a week back. And what this basically shows that in the Canadian Neonatal Network, if you look at 5 tertiary units between 24 and 29 weeks management of babies, a large population cohort of 1,581 babies, whether you use the T-piece or whether you use the anesthetic bag, you actually achieve similar outcomes with regards to PEEP success, intubation, and when they analyzed the long-term outcomes of those babies in terms of IVH, chronic lung disease, they did not find any significant difference in those outcomes. Their key message was that provider training is the most important aspect in providing non-invasive ventilatory support and its success. So again, I can't emphasize enough how important it is for you to be having good training programs in this regard. Does mask make a difference? Is there any particular kind of mask that provides better PEEP than the others? Again, I've reviewed the literature, and a distinct giveaway is that there are no benefits of using any particular mask. There is one study at this particular point that talks about nasal prongs that I will discuss. But again, there is no particular benefit of any particular method of hold that provides better PEEP. The key thing is using the right size mask for the right baby, using the right technique, and MR SOPA where it's not working. If you look at training, I wonder, are any of you using respiratory function monitors for training in your units at the moment? Anybody? So at the moment, we use Monivent training, and I've used that in Southampton for 2 years. I've now introduced that training in the Corniche. And the idea from our perspective is we train baby fellows and my specialists in the use of a round mask. The intention of that training is basically to improve their ability to deliver PEEP. And because we all have different hand sizes, it encourages them to use and choose the best grip that they can use to minimize their leak. And what is very interesting is when you do that training, you can tell if a person is putting or applying a mask very forcefully just by looking at his finger and his thumb. You can see the finger and the thumb blanch. You can see that he's applying and he's very stressed about his approach. And using this, what we've been able to demonstrate is that before and after training, you can actually not just reduce their leak, but you can actually improve their ability to be able to provide mask seal and provide gentler CPAP to babies in the delivery suite. It's work that we will be publishing soon. In terms of a comparison between masks and binasal prongs, this is a piece of work that was done in 2021 by Snorri Donaldson and his group. And what they did demonstrate is that for breathing babies, for babies who have good respiratory drive, the use of binasal prongs resulted in less intubation as compared to the face mask group. Now, this is the first study that raises the importance of the risk of too much pressure causing trigeminal cardiac apnea. And really, based on this, they hypothesized that if you're using a mask and you're using it very hard, you might actually be making things worse. So binasal prongs, which fit onto the nose and don't cause that problem, might be a better option. I just want to point out it's a very small study on very small numbers, and it's one center. So again, you have to just be very cautious about applying it. This is the Fondue trial, and this was published last month. And really, this was a trial to try and elucidate whether there can be problems with use of the face mask and whether just use of a nasal mask without prongs might help babies breathe better and result in better success in PEEP delivery and delivery suite and reduce intubation. Now, again, a very similar number to the previous trial, randomizing 75 babies into each group roughly, a mean gestation of 28 weeks. This did have babies down to 22 weeks of gestation. And really, if you look at the number of babies who were born before 28 weeks, it's 35%. So, it's a relatively large number of very preterm, extremely preterm babies. What did they do? So they basically applied CPAP in the first group by mask. And in the second group, they applied a nasal mask. So these videos are courtesy Brett Manley, who's done the study, so just to acknowledge him. Now, the difference between the two groups was quite striking. So actually what they found is that babies given nasal CPAP were less likely to be intubated, were more likely to be brought to the neonatal unit on CPAP, and had a much lower rate of intubation as compared to the babies who were given mask CPAP. So from our perspective, that then does raise the question of whether using a nasal interface or nasal prongs has its benefits in being able to keep these babies on PEEP. Again, it's one study, small numbers. I'm not sure that any of these studies at this particular point categorically say that we should be changing practice. But what I would say is it's really important that when we're using mask-based CPAP, which is what the majority of us are doing, that we're doing it gently, with good seal, and with good training. Just a few of the clinical bottom lines. Nasal mask and nasal prongs are feasible alternatives. If using a face mask, choose the appropriate size, use gentle pressures. Seal is important, not how hard you push the mask. And provider training is probably the key. In terms of ventilation devices, just a very quick overview. How much time do I have? Okay, so just in terms of ventilation devices, I just want to give you a flavor because all over the world, we have different units using different ventilation devices in delivery suite. And my worry is that not only is this very costly, you can imagine if you want to deliver NIV in every delivery room of your neonatal unit, having a ventilator there to effectively deliver it for an extremely preterm baby who could pop out at any moment is going to be a very, very expensive affair. At the same time, if you then modify resuscitaires so that you can keep ventilators on them to be able to move them, what do you do about twins, triplets? We've had quadruplets recently born at 26 weeks. So I think we need to be pragmatic about whether there is really good evidence that any of the ventilation methods that we're currently using are any better than the other. So we can deliver high flow, we can deliver bubble, we can deliver BiPAP and NIV, and then there's nasal high frequency. So is there any really good evidence that these are any better than mask-based PEEP and CPAP devices in the delivery room? Can I ask with a show of hands, who's using mask-based CPAP in delivery suite at the moment? Okay, so I'm gonna, because that's the whole of the UAE. Yeah, we're all using, we don't use anything else. Anybody using BiPAP in delivery suite? Anybody using NIPPV in delivery suite? Great. High flow. So there is no high quality evidence that Optiflow at birth is any better than provision of PEEP or CPAP in delivery suite. There is good evidence of a very high treatment failure rate. In fact, for every 15 babies provided high flow compared to CPAP, meta-analysis shows that 2 more babies will fail for every comparison. I think the most important thing from our perspective is not only are there no randomized control trials, we've got to be very cognizant that there are only 2 centers that have actually demonstrated feasibility of its use under 25 weeks. And we're talking about 20 babies in the literature. So a word of caution, I would say that before embarking on an exercise using this, I would be very cautious about making sure your staff are very well trained. CPAP is the most common modality that we use. There are, from our perspective, besides the use of the resuscitaire, other ways to deliver it in delivery room. And in Southampton, we use bubble. It is something that can be put on the resuscitaire. One of the advantages that it does give over mask-based PEEP or just using a nasal interface is it humidifies. That helps with hypothermia as well. And it's part of a quality improvement exercise that was implemented when I was leaving. I haven't followed up to see how successful it's been. There is still no high-quality evidence from papers that shows that BiPAP, CPAP, or Optiflow are any better than mask-based PEEP at this stage. So again, I'm not sure the device actually matters. I think it's really the PEEP provision. There is one single center retrospective study that shows that the provision of NIPPV is feasible in delivery suite. It needs a ventilator, it provides humidity, and that in some of the work done, there is decreased intubation in that group of babies. But do take that with a pinch of salt because that study, even the single center study, did not show a large number of babies under 28 weeks. So I'm not sure that you can justify the cost in the setup that I work based on the success rates that we have. And there is no evidence for use of nasal high frequency at birth. No randomized controlled trials, no single center trials. If nasal high frequency is being used, it's being used as a primary support method in the neonatal unit, not in delivery suite. I think a summary of what I'm going to put to you today is that there is an absence of any high quality evidence that any one method is better than the other. My take-home message to you would be that if you're using something that works for you, then you should develop quality improvement strategies that look at training your colleagues, your teams, and I'm going to talk about that in my next talk, in how to deliver PEEP effectively. That is gently, with a good seal, with the ability to minimize the change in interphases so that you keep your functional residual capacity. In Southampton, the data that we have shows that between 26 and 29 weeks, we were able to decrease intubation by 20%. We, after a trial of PEEP in extremely preterm babies, decided that we would intubate them because the failure rate of PEEP was 90%. 9 out of 10 of our babies was needing surfactant. And we struggled a little bit with Lisa based on our setup. So we have gone for intubation in that group. Again, you should decide what is most appropriate for you. The second thing is that PEEP via face mask remains the most common way of delivering PEEP, but there is going to be a very, very high failure rate, especially in the extremely preterm group. So in the support study, which had 24 and 25 weekers, the failure rate was about 83%. In all other studies, it varies between 50 to 60%. And that brings into the importance of the next talk that's going to be given by one of my colleagues, which basically talks about the need for surfactant. So with that, I'm going to end over here. Thank you very much.
Thank you so much, Dr. Alok, for this interesting lecture. Your lecture was very useful for all neonatology because the outcome of all preterm start from delivery room. Thank you so much. It's my pleasure to introduce next speaker, Prof. Saad Al-Saidi. He is a professor of pediatric and neonatology, Faculty of Medicine, King Abdulaziz University. He's also working as consultant neonatologist at King Faisal Specialist Hospital and Research Center. He's going to talk about Lisa and SALSA challenges and solution from bedside. Take your time, Prof. Saad.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Muhammad Hakami. It's my pleasure to be with you in this prestigious conference, and I would like to thank my colleague in the organizing committee and in the scientific committee for calling me to give this presentation, which is really, I'm sure that most of you know a lot about it, but it's, I think, a very good time to review the subject. I have no conflict to declare. Just during this presentation, I try to cover the following areas. A brief history of ensure and less invasive surfactant administration, because nowadays really become more issues. More interested with the good outcome compared with intubation. The benefit of not Lisa, because we like this name, Lisa, right? But when I talk about Lisa, it's less invasive surfactant administration, not something else. Don't take me wrong, right? And also the importance of team approach when we apply Lisa is not one-man show. It's really need a respiratory therapist, physician, nurse, to do it in well-coordinating way. The importance, maybe you will also talk about side effect and complications. Does Lisa make a difference in the outcome of extremely low birth weight infant or not? A Swedish neonatologist, Victorine, was the first to treat infant with short time intubation, surfactant administration, and extubation, which we know, we call it nowadays Ensure, in Kuwait in 1990s, where at that time, the hospital he works in, there was no ventilators. So intubate, give surfactant, and then extubate. The delivery of oxygen surfactant by using a thin catheter, which was it was, and still in some center, feeding tube or angiocatheter, though nowadays there are some companies where they sell a catheter design for this. In spontaneously breathing infant on CPAP, I think my colleague has said it several times, I think, the importance of CPAP. This, they call it LISA or mist or salsa. Don't take me wrong, salsa is not the food, is supraglottic administration of surfactant. This is, for example, LISA, you need, in most of the center, they use a forceps. Also, you need intubation. You use the administered surfactant. Though with this method, there is some side effect because when you intubate, it may stimulate fecal response. You discontinue CPAP sometimes. That lead to some people talk about salsa, where here there is a catheter, supraglottic catheter. You don't need to intubate. And also, on the other side, there is a place to give surfactant administration without, very important, without interrupting CPAP. Because if you stop CPAP, about 50% of the benefit of non-invasive is gone. And matter of fact, this is one of the advantages of LISA and others. This is the supraglottic laryngeal catheter. It's really a good idea. There are some studies on it, though the problem is with the size. You cannot use it in extremely low birth weight infant because the available size now may be good for 700-gram babies and more, or babies with 27 weeks gestation or more. I don't think we have, as far as I know, a very small size one to use it in 22, 24 weeks preterm infant. Though, despite of the literature, they say they talk about the success of LISA in this gestation, as most of them, from my little experience, 22, 23, 24 weeks, most of them, they need intubation from the start. So, Danish neonatologist Henrik Verdor was the first to use a small diameter gastric tube to administer surfactant in spontaneously breathing babies in 1992, which is a long time ago. However, the method of using this catheter rather than the AT tube was rediscovered again about 9 or 10 years later, when there was a small study, consists of, I think, 14 or 16 patients, addressed the benefit of it. Though, after 9 years. This is the importance of studies. It's to address in... So what's the advantage? This is transcatheter administration, which when you talk about it, whether LISA, whether salsa, or mist. This together, we call it administration of surfactant through a thin catheter, whatever the way you use. Number one, avoidance of a brief intubation. And this is compared with Ensure. Avoidance of positive pressure ventilation. Though sometimes you have to use it, but really minimize it. And also reduce complication due to airway manipulation. And Dr. Sharma talked about it there are some complications, not in every patient, but you need to avoid it. Yani for example, when you manipulate the airway, one simple thing, just example, it may affect the blood flow to the brain, fluctuation of cerebral blood flow. This vulnerable infant, preterm infant, is one of the risk factors for intraventricular hemorrhage. Just one example. Improve the successful of CPAP after surfactant administration because you not stop it. When we compare transcatheter administration of surfactant with Ensure, which is intubation, surfactant administration, and extubation, it has been shown that there is improved lower rate of mortality, need of mechanical ventilation later on, as well as bronchopulmonary dysplasia in those who received transcatheter surfactant administration. Several studies has been shown that when you compare Ensure group with transcatheter administration of surfactant, it has been shown that less need for subsequent mechanical ventilation, shorter duration of supplemental oxygen, as well as in some studies shorter hospital stay, as well as lower rate of supplemental oxygen at 36 weeks corrected age, post-menstrual age, which is chronic lung disease or BPD. What's happening? And this is a matter of fact, mainly in low income and middle income countries. Because, intubation and mechanical ventilation in some low income or most of low income and some of the middle income countries, they don't have the expertise to intubate. They don't have the machine or the tool to intubate. It's easier to give surfactant through a thin catheter, and this has been studied, as has been shown to be safe and can be done. Just to talk about LISA, it's become actually standard in most of the units in Europe, Scandinavian countries, Canada, as well as United States. As a matter of fact, a lot of these countries, they have guidelines how to use it and using it. So it's a matter of fact, almost a standard of care. The LISA, I'm going to stress on this, LISA is needed to combine the surfactant administration with CPAP. Those two are very important issue when you take care of respiratory system in preterm infant. What about the scientific concept of LISA? Number one, intratracheal administration of surfactant without endotracheal tube intubation. This is number one. Number two, introduction of thin catheter rather than the ET tube procedure. Number three, surfactant will be administered through this catheter, and CPAP is used with the procedure to transmit the airway as well as to push surfactant from upper airway to lower airway. So allow infant to keep on breathing, that's very important, and also without obstruction of larger diameter endotracheal tube, as well as use, as my colleague Dr. Sharma mentioned, use the physiological function of the larynx and epiglottis. Patient conformed by avoiding mechanical ventilation. So, as we said before, there is a lot of mode of non-invasive ventilator, and just for example, this is studies showed, I don't know where's the pointer, maybe here, no. From 2009 to 2017, this is one of the study, involved about 4,400 babies. There is increase in the use of LISA, the continuous gray line, and also in the same time there is decrease surfactant administration through the endotracheal tube and mechanical ventilation. But in the same time, there is increase on the opposite side, giving surfactant through LISA method. But also, number of surfactant decrease. So this has no relation to the surfactant, but probably because nowadays we use other method. For example, maybe antenatal corticosteroid. There's more awareness since 1992 or 93 of the use of antenatal corticosteroid, though it's there since 1978 or more. But the people were at that time were afraid until there's consensus in 1991 or 92 of the use of antenatal corticosteroid for those going into preterm infant from 24 weeks to 34 weeks. So probably this is another factor in the decreasing. It's not just because. LISA is appropriate, as I said before, for most infant with a gestational age equal or more 26 weeks. And also or 700 grams or more. However, infant less than 25 weeks, LISA was effective in keeping infant free of ventilation during the first day of life. But however, study has been shown significant number of those infants, they may need ventilation, intubation and ventilation in the coming 72 hours, either from fatigue or from other complication. So intubation was needed in more than 90% of those infants due to apnea or muscular fatigue, I mean those less than 25 weeks. Also this mechanical ventilation within the first 72 hours, it's inverse relationship between it and the gestational age. So the younger gestational age at 27 weeks, 22 weeks is the maximum, and then decrease. Okay, what about bronchopulmonary dysplasia for those infants? So there is no pointer here. Excuse me. Oh, I didn't see it. Thank you very much. Anyway, this is from 22 weeks and 30 weeks. Look at the bronchopulmonary dysplasia. And the dark here, no surfactant administration. This one, LISA, and the solid line tube surfactant. It seemed to be, as you see, it's bronchopulmonary dysplasia decreasing with use of bronchopulmonary dysplasia increase as the gestational age decrease. So this is 24 weeks, and this is, as you see, is no surfactant, and this one with Lisa, and this is with tube surfactant. If the patient intubated, bronchopulmonary dysplasia increase. And this is grade 3 and 4 IVH, which is a nightmare for the parents and for the neonatologist. And this is also, it seemed to be, there is a significant decrease in the IVH in those babies who received surfactant through transesophageal, through thin catheter. And this is actually shown in different studies, not only this study. So, it's decreased the incidence of bronchopulmonary dysplasia. It's decreased also intraventricular hemorrhage. In some studies, it's decreased the hospital stay and decreased the need for oxygenation. However, some studies in Europe, they found this effect, this good effect is different from center to center. Why? Probably, as we said, is Lisa is not one-man maneuver. It need training, need well-organized team, need the presence of guidelines. This, of course, different from center to center. So, according to assumption, that Lisa procedure itself could be, nobody knows, handling of the infant in the first hour of life. Nowadays, most of us start CPAP in the labor and delivery, if it's away from most of us administer surfactant in the labor and delivery if needed. So this is not applied in all centers. Some centers, they don't start this maneuver until they reach the NICU. So these are very important to maintain the baby breathing during the procedure. And Dr. Sharma said before, avoid unnecessarily manipulation. As we do a long time ago, once a baby delivers, suction, upper airway, through the nose, through the mouth, baby stop breathing, phagal reflux, stop. So start CPAP, very important to start CPAP nowadays. A lot of literature support the use of little bit, 6 to 9 CPAP, not 4 unheard of nowadays. Some people, they stick to 5, but I think most of the center use 6 to 9 nasal CPAP. طيب. About 16 randomized studies published between 2012 until 2020 involve about 19,000 preterm infants. 11 studies showed shorter duration of mechanical ventilation and CPAP in the Lisa group compared with Ensure. This is number one. Ensure group were compared with Lisa had a high risk of mechanical ventilation in the first 72 hours, in pneumothorax, and periventricular and intraventricular hemorrhage, and mortality. What makes Lisa different? As I said, and I repeat several times, it's a component of complex care bundle. Okay? And LISA is not only single technical procedure to take care of premature babies. Okay, you can concentrate in LISA procedure, but the patient is hypothermic. You forget to take care of hypothermia. And we know nowadays that hypothermia is very damaging to the preterm infants. So, also, as I said, antenatal corticosteroid, I think very important for maturation of the lung for babies born between 24 to 34 weeks. Right time to deliver a baby in a good condition. Like this is the decision of our colleague in the obstetric. And not to, don't do it early unnecessarily, but in the same time, don't wait until the patient suffer in utero. And there is a lot of judgment, and it's not an easy job, but you do whatever you can do. Efficient CPAP therapy. CPAP nowadays, CPAP was discovered, the first one who used it in neonate is Dr. Gregory George Gregory in 1971. But Dr. Wong, he's the one who invented the bubble CPAP, and he used it more and more, even in this very small preterm babies. Avoid hypothermia, as I said. Avoid unnecessarily manipulation. We do a lot subconscious in the delivery room.
5 minutes.
Okay, like, wallahi. So, as I said, now LISA guidelines in a lot of units. Question with no clear, specific answer. Technical issues need a lot of training. The exact indication and treatment threshold for different group of patients. There's a lot of judgment. We are not in the same. The surfactant dose question still not answered. Is it the same dose as the dose we use for endotracheal intubation? Most of the centers, they use it, but we don't have enough study to use what is the best dose, as well as analgesia and sedation. Is LISA a safe procedure? It requires specific skill. It should be performed by physician experience. There is a lot of videos in the internet to show the procedure, and also mannequins to train the staff. So to sedate or not sedate, I think this is a very important question. A lot of us, sedation, we use, for example, what? Ketamine, other analgesia. But the problem of it, also, for LISA, maybe suppress the airway. The current recommendation is if the intubation not necessarily or not urgent, before any intubation, some center you have to give pre-medication. They're different from center to center. It's an ongoing debate about whether this recommendation should be applied on LISA, because if you give sedative analgesia, it may suppress the airway, and then you intubate. But most randomized control trial and observation studies, they use the non-pharmacological method. Like what? Like dextrose, okay? And also swaddling and facilitated talking and other. And So the use of LISA does not exclude analgesia and sedation because the pain, but better to use other method rather than the usual sedative for intubated patient. In survey, 52% of neonatologists in Europe and 94% in USA do not use analgesia sedation for LISA. Is there any side effect for LISA? Yes, of course. Use of analgesia sedation during ET tube intubation. Also, as I said, most of the time they use fentanyl, ketamine, or propofol, but not recommended for LISA except if it's necessary. So better to use because it interferes with breathing and other. So better to use non-pharmacological like intraoral sucrose, swaddling, and facilitated tucking. So LISA and gestational age, and I think I talked about it. The failure rate is slightly high if you use it for, it's understandable, for 22, 23, 24 weeks. Some people, they use it, but also most of the people, when they reach, for most premature infant, if they reach 30% of oxygen, there is indication to use LISA. However, if the patient uses more than 60%, particularly if they have severe respiratory distress, better to intubate. Is there side effect due to LISA? I think أنا رجعت للخلف ولا لا؟ Surfactant reflux is very common, and anyone who did LISA, this is one of the problem. You have to stop a little bit if there is any reflux. And as a matter of fact, sometimes you have to use a mubagi. Failure to insert the catheter through the vocal cord at the first attempt, it's happened. And also desaturation, apnea during manipulation. It has been reported in 10 to 30%. The highest incidence of such complication in those premature baby, more than 32 weeks, and sitting that interrupted CPAP. But most of those babies, they don't have bronchopulmonary dysplasia and others, lower risk in IVH.
Time out, Dr. Saad.
Like, to treat early with continuous CPAP and use non-pharmacological cause, short-term needs side effect, okay, I'm not going to talk about it. Timing. Long-term follow-up, as I said, 33% reduction in the rate of rehospitalization, less symptoms of chronic lung disease, less need for bronchodilator therapy later on during childhood. Infant LISA group in NINSAB trial had comparable lung function test during childhood compared with the control. This also studies follow-up LISA in German neonatal network, suggests that lung function is better, in neuro outcome and intellectual component is better in patients who received surfactant through CPAP. However, SALSA, I think this is maybe no time to talk about it. The use of the laryngeal mask to deliver surfactant in preterm infant with RDS was described first in 2013. Should I stop or complete? خلاص؟ طيب خلاص. إذا wrap up. نعم. تبغوا تسمعوا صلصة؟ If they allow me.
طبعا دكتور سعد تفضل.
لا بس عشان الوقت معلش. طيب take home message. على فكرة بس هنا إذا تبغوا أي حاجة عن صلصة في study they didn't Cochrane review, by the way, recent Cochrane review, it didn't show that there is a difference in chronic lung disease, bronchopulmonary dysplasia, and IVH and other for SALSA. but طيب. So the use of non-invasive respiratory supports such as nasal CPAP and non-invasive ventilation of preterm infant is well studied, and the use of oxygen surfactant are a turning point in the history of neonatology, using CPAP and oxygen surfactant. LISA is a safe procedure. It has been shown that it reduces bronchopulmonary dysplasia, grade 3 and 4 IVH, neurodevelopmental outcome in very low birth weight infant. Non-pharmacological methods are preferred for analgesia and sedation during the procedure. More studies are needed regarding the routine use of salsa. Some center they said, or some reference they said, they recommend to use it as a part of study, not as a routine. Thank you very much.
Dr. Saad, for sharing your insightful lecture with us. Now help me welcome Dr. Sharma again for his second talk.
So just while we're waiting and to talk about this topic, which is a topic that's very close to my heart, can I ask how many of you monitor your delivery room outcomes in terms of achieving certain milestones? Like, do you measure CPAP failure? Does anybody measure CPAP failure in delivery suite by gestation? Does anybody monitor the temperatures on admission to the neonatal unit? So a lot of, yeah, fantastic. So what I'm going to talk about today is outcome-based neonatal resuscitation, specifically talking about the relationship to preterm babies. Actually, my implementation of outcome-based resuscitation is not limited to preterm babies. I have worked on quality improvement projects in conditions like CDH, gastroschisis, and the most recent one that I've worked on with my tertiary sister hospital, SKMC, is actually the management of babies with transposition, where we had quite a high mortality. But the most important concept when we're talking about outcome-based resuscitation is that really, whilst we're resuscitating, we're moving towards achieving certain tailored outcomes as an outcome of that resuscitation process. And a simple example that I'll give you is that, in our extremely preterm babies, we want to achieve thermoneutral temperatures of between 36.5 to 37.5 prior to leaving the delivery suite. It's really important that we've achieved that target. But if we haven't achieved that target, the emphasis of using a thermal mattress, which we know causes hypothermia if it's used together, is one step. And then the second step from our perspective is getting that baby into a humidified environment. Now, I work in the largest unit in the UAE. We deliver about and manage 1,300 babies every year. About 220 to 250 of those babies are born under 32 weeks of gestation. I arrived there in 2019. Guess how much hypothermia we had in the group under 32 weeks. How many babies do you think between 22 and 32 weeks were hypothermic in the biggest tertiary unit in the UAE? 20%, 30%. So it was 46%. So 46% of our babies came in with a temperature under 36.5 degrees Celsius. 18% of them came in with temperatures under 36. We had babies coming in with temperatures under 35. And that is despite using plastic bags and transformers. So what is very important is that we had absolutely no idea about what was happening during resuscitation, and really we had no targeted outcomes to work towards really how we manage the situation. And this concept really needs improvement through feedback in real time. So what is important is that you have a measurable outcome during resuscitation that you're working towards, and if you're not achieving that outcome, you have some sort of feedback which says, okay, this baby is still hypothermic, what are you going to do next? More importantly, if you have a baby who's hypoxic, who's not lung inflated, and whose lungs are not recruited, the key question is, do you need to go up on PEEP? Do you need to go up on FiO2? And who's going to give you feedback about whether you're actually effectively ventilating that baby? Are you moving the chest? Or is this a human factors issue? Your mask is not the appropriate size. And a really big problem is when you go in with 3 or 4 member teams and nobody has that global overview, there's absolutely no feedback, which means you can't make improvements in real time. Now, for an individual baby born between 22 and 26 weeks, that's not good enough. So really, what we've done is we've worked towards a quality improvement package which basically focuses on the concept of outcome-based preterm resuscitation. And what does that say? So if you look at normal algorithms, and I'll come back to this slide, normal algorithms like the NRP, and this is the 8th edition, and today you are going to get the 9th edition soon. But it talks about performing resuscitation as a flowchart. So let's inflate the chest, clean, warm, and dry. Let's listen to the heart rate. The heart rates come up, that means we've inflated the chest. Eureka. Okay, the SATs aren't coming up, let's turn up FiO2. In reality, rather than use the NRP as a flowchart, what I want to do is I want to change your mindset. I want to say that you can actually keep the baby warm, inflate the chest, improve saturations simultaneously. And that is called the pit stop approach. So the intention is if you have a dedicated team where a person is looking after the airway, he's providing PEEP, he's never going to lose his seal, and he's keeping an eye on the baby's breathing and stimulating, he is likely to be successful. But if you then have the baby put in the plastic bag at the same time, or even before he arrives with you, he is already in a warm environment. The key thing is he in the center of the incubator? Is the heating 100%? Have you had time to prepare? So by having an additional person, who we call a CPR coach in my setup, that person verifies that all those things, temperature is maxed up, the baby's right in the center of the incubator, and there's a nurse who measures temperature at 10 minutes. And she tells us, and if we have not achieved a temperature of 36.5 in those 10 minutes, that baby goes under a transformer. If we do not achieve a temperature that is within the normothermic environment, the emphasis is admission of that baby. And that admission into a humidified environment needs to happen now. We do not have time. So we look at those outcomes in parallel, not as a flowchart. More importantly, from our perspective, we know that the NRP is modified by guidelines that are adapted to your local setup. And a simple example that I'll give you. Why do we intubate most of our babies under 26 weeks? We don't PEEP them in the Corniche. A good reason for that is most of them don't breathe, only 40% breathe. We then have to move the baby from labor suite to the neonatal unit, which basically entails going through 2 sets of lifts. It's a very long distance. We have a lot of other reasons why PEEP is going to fail. So we've adopted a strategy where we tend to intubate them. So the priority during outcome-based resuscitation then is IPPV, achieving saturations of 85% and a heart rate of above 100 by 5 minutes, and then moving towards ventilation. But at the same time, temperature is being monitored and worked on. Now, as I said, this is our protocol under 26 weeks. Sorry, the marker's not working. But for any baby between 26 weeks and 32 weeks who's breathing, we will follow the PEEP-based strategy and minimize the number of interface changes that the baby has to allow PEEP success. But part of that PEEP success is keeping the baby normothermic. If I have an unrecordable temperature at 10 minutes, do you think my PEEP is going to work? Do you think my saturations are going to pick up? There's going to be pulmonary hypertension. So I'm succeeding in one area with lung inflation, but I failed completely in the other area. So unless you look at those outcomes simultaneously and you get feedback about where you're failing, you're not going to be able to improve those things. So how do we do that? So in the Corniche, we have a strategy which is called, so I implemented this first in Southampton in 2017. It's called the pit stop approach. It's something that we practice day in and day out. And what we realized is that we just do not have enough staff. For any baby under 28 weeks of gestation, I need 4 people as my team. I need a person for the airway. I need a second person who basically manages cardiovascular, who feeds back, who tells people what the heart rate is, who basically has good communication. I then need somebody for thermal care and equipment. That is usually a very experienced nurse. And I need a 4th person for global overview. He is the CPR coach. So if any one of these people are failing in their actions or we're struggling, he has the ability to be able to step in and try and change things. Or if we've not had time to prepare, is the heater on 100%? Have we put the SATs on preductally? Are we in a situation where the plastic bag is covering the baby in completion, not just over here? So you have somebody who can intervene, feedback to the team to try and improve their performance. Now, we've agreed that for all babies under 28 weeks who have no risk factors, we will have a minimum of a 3-member team. And at the time that it is envisaged that we may need compressions or access, we will call a 4th member of the team. And that is really what I would say is the person who then acts as the CPR coach. In an ideal world, I would have liked 4 people, but we just can't tailor that. What we normally do in these circumstances is that we follow a structured process, which is a preterm huddle prior to delivery of the baby. We discuss roles, plans, and action. So the idea is if I have a preterm 23-weeker or 22-weeker on delivery suite, delivery is imminent. The day team basically will have a consultant, a specialist, maybe 2 specialists, a nurse, and an RT. So we will all have a huddle, discuss which room she is in, check everything, check the equipment that we need, make sure that we have known roles. So who's going to manage the airway, who's going to be circulation, who's going to be temperature and equipment. And really, if the baby is imminent delivery, as soon as the delivery delivers, a code is put out. If we think we're going to need compressions, we ask for a 4th member, and that person really acts as the person who's the CPR coach. We've also standardized our communication. So really, intubation means a tube, CPR means codes, and that just means that you can communicate more effectively so that people know what's going on. Now, what outcomes are we working towards? So, simple 25-week baby, steroided antenatally, gone into preterm labor, no indications for putting this mother through a cesarean at this point, likely to deliver vaginally, could deliver at any time. So the midwives need to put out a code to get us there, preferably prior to delivery if it's imminent. But delayed cord clamping is one of the most important aspects of management of extremely preterm babies, and we want to ensure that 30 to 60 seconds of this happens. Now, culturally, we're not allowed to be visible to the mother. And that is a real challenge. So our midwives have had a lot of training in managing delayed cord clamping. Is the baby breathing? Is he showing signs that he's vigorous? He's not floppy pale. Well, we want to ensure that he gets 60 seconds. But we also want to ensure that he goes into a plastic bag. So our plastic bags are kept in the rooms. So that as soon as the baby delivers, no cleaning and wiping. The midwife will put him into a plastic bag while a cord is being picked. So that means that when I arrive there, the baby's already in a plastic bag. In theater, it's easier. You can be put in a plastic bag straight away. But more importantly, as soon as we arrive, the airway 1 person basically works towards PEEP if the baby's breathing over 26 weeks, or works towards PEEP and IPPV if the baby's not breathing with a view to intubating. What we want to achieve is 30 to 60 seconds of delayed cord clamping, simultaneous thermal care to achieve an outcome of 36.5 to 37.5 by 10 minutes of age. And by 5 minutes of age, based on Decker's work, we want to achieve a heart rate of about 100 with saturations of 85%. Now, I'm not saying there's high quality evidence based on Decker's standards that this is really something that we should aspire to. But it is an outcome-based measure that we have chosen as part of quality improvement that we aspire to in our unit, because there is low-quality evidence that it decreases the risk of IVH. And we have an IVH rate of 10%. So really, for us, it's quite important that we work towards it. Clinical perfusion is more assessed. I know that in certain countries, and I will show you a paper, they're now using NIRS in delivery room, and they're measuring cerebral saturation indices to kind of establish that we have good cerebral perfusion by about 15 minutes of age in babies who are being resuscitated who are extremely preterm. They have developed centiles for this, which were just published day before yesterday. At the end of the day, the DT-ABC approach needs to be completed within a finite time. So I'm just giving you a flavor. We had people spending 40 minutes resuscitating babies, 23 weeks in our delivery suites. The golden hour is gone. We have no access. What is the baby's glucose? We were struggling because we couldn't achieve those targets because the amount of time being spent handing over and documenting whilst we're bringing the baby to the neonatal unit is actually resulting in poor outcomes. So we've worked on that. I've talked a little bit about delayed cord clamping in the processes. We followed a time-based physiology. We do not provide ventilation at this particular point whilst we're doing delayed cord clamping. Anybody here providing ventilation with their DCC strategies or using a LifeStar trolley? So there's no good evidence at this particular point from Anup Katharia's work, even now, that there are any benefits from ventilation being introduced. I think the most important thing from our perspective is how you keep babies warm while you're doing delayed cord clamping. Now, that is a baby who is wrapped all the way to the top. He's got a hat. You now have Neo Helps, which are used, which basically mean that you can put the baby in a wetsuit. We've just transitioned to using them. But the intention is we tend to cover every millimeter of the baby. And we measure temperature. Now, how you can measure temperature for feedback and delivery suite, even in the extreme preterms, is if you're using a Draeger, you can use servo control. I've used that in Southampton. And we achieved 0 hypothermia for 3 years. Not a single baby between 22 and 32 weeks was hypothermic on admission to my neonatal unit. We were ranked first in the whole of the UK using servo control as a methodology. Servo cannot be used on every machine. It's not as effective. So what we did was we basically did a prospective observational study to make sure that servo, when it was used, correlated with other thermal measures. If you don't and can't use servo, you can still measure temperatures at 5 and 10 minutes. And if your baby is hypothermic, you can put the baby on a transformer. If he's still hypothermic, you need to admit him to the neonatal unit. We measure temperature by basically using we tend to go into the left axilla for placement once the baby is in the plastic bag. You can also put a probe on the back, but you can't see it. In terms of lung inflation, like I said, a PEEP-based strategy for babies over 26 weeks. Now the question is, if PEEP is not working, or if your heart rate is not improving, or your saturations are not improving, what are you going to do? So I'm just curious to hear from the audience. Are you going to put your PEEP up first, or are you going to use FiO2? PEEP? So, show of hands, how many of you are going to go up on PEEP first if the baby's breathing? Okay, anybody going to go up on FiO2? Yeah. There is no current evidence to basically say that one strategy is better than the other. But we have a high CPAP failure rate. So lung recruitment becomes an essential strategy, because if your lungs aren't recruitment, you can go up on FiO2 as much as you want. You haven't really recruited enough lung to be able to keep the baby breathing. So what we have agreed as a group is that we're actually going to increase CPAP pressures in increments every 2 minutes, but also increase FiO2 every 30 seconds. And really, a significant amount of the FiO2 titration is kept to clinician discretion. The most important thing is that if we're PEEPing breathing babies, we do not break the seal. The airway person keeps it there. He manages the baby. His intention is not to disconnect unless we're in a situation where the heart rate is not coming up, in which case you then have to do MR SOPA. Now, I'm going to skip this. What is and how do you get lung inflation feedback? How do you know that you're actually ventilating? Because on PEEP, the baby is breathing. So the most important aspects are improvement in heart rate and saturations. Any other methods? Anything that anybody else knows of? So at this particular point, there is the use of what we call as respiratory function monitors and the Monivent, and I would talk about that a little bit at the end. But really, it's rise in heart rate and saturations that guides us. And if they're not coming in, you will inevitably then resort to IPPV. Now, are you moving the chest? And that is where the CPR coach comes in. If you're not confident about moving the chest, 2 people can confirm you're not moving the chest, and that would be an indication for you to do MR SOPA, increase your pressure in rapid increments to be able to achieve that. Now, that feedback is sometimes very difficult for one person to judge, and in the smallest babies, that can make a big difference. But this is what is on the horizon. So we now have monitors where we're providing IPPV, which monitor not just the mask leak, but actually provide us with tailored tidal volume reports and feedback about what kind of pressures we are providing to that baby. The most common device in the market is the Monivent Neo. We use it for training. We're not using it clinically at the moment because it's not been approved by the FDA. But there is one trial which basically shows that in babies between 29 and 35 weeks, It provides very good and effective feedback to the people providing IPPV about really whether they're effectively ventilating or not. And when you use that in conjunction with chest wall movement and rise in heart rate, they did a parallel crossover study with people who were not using it and found that you were more likely to achieve a rise in heart rate and saturations in the group that used this than in the group who didn't. There is on the horizon the use of NAIRS, and I talked about the fact that we don't have centiles to know what cerebral perfusion monitoring we need to aim towards, but that has just been published last week by George Smolza and his group. And really, not only have they published parameters of saturation in the cerebellum, but they've also published SpO2 heart rate and FiO2 specifically for extremely preterm babies. Now, the current nomogram that you use, that I use, that basically talks about saturations of 85% at 5 minutes, only had 25% of babies under 28 weeks and very few babies at 23 and 24 weeks. This is a very large trial, 207 babies under 32 weeks only, with a very large proportion of babies born at 23 and 24 weeks of gestation. Eventually for us, what we wanted to do is, we wanted to improve our temperature on our admission, we wanted to improve our CPAP success, and really some of that is judged by effective ventilation, good heart rates, and saturations of 85% at 5 minutes. So we have done the data. So we implemented our thermal care pit stop approach in the third quarter of 2023. A lot of the education was done in the first and second quarters of 2023. And what you can really see is that if you look at the hypothermia rates, 50% of our babies under 28 weeks are coming in hypothermic, some of them with temperatures under 36. Really, again, during the training, I mean, this is virtually the entire cohort of babies under 28 weeks, which is hypothermic in the second quarter. But as we've moved on, we've been able to bring that down quite significantly. Sorry, these are admission times. I apologize. Showing you the wrong slide. Yeah, this is the thermal care. So 60% of our babies are hypothermic. 50% of our babies are hypothermic. And with education, what you find is that this reduces to about 22%. Our targets have been to try and get them down to 30%, now 20%. So for the first time last year, in December, we had no baby under 28 weeks hypothermic. Only 3 babies who are hypothermic. So we've had success rates in reducing our incidence of hypothermia. If you drop the education and you become a little bit more blasé, the rates go up again. So you have to continue doing the education, especially with new staff that come in. But what we also know is that if you don't admit these babies to the unit within a finite period of time, your golden hour is never going to work. Now, just to give you an idea, the curve in red shows the number of babies under 28 weeks where it took more than 30 minutes to get them into a humidified environment. 50%. A good month over here. But again, very high rates, 24%, 19%. And again, in the final quarters, what we've been able to do is actually increase the number of babies in dark blue, which is under 20 minutes coming to the neonatal unit under 28 weeks. I haven't been able to show you our CPAP rates yet because I'm collecting them, but we've been able to improve CPAP failure between 26 and 36 weeks by 20%. So this is the concept that I'm trying to espouse, that really you should be working towards trying to improve the outcomes that you want to achieve through delivery room resuscitation, because actually those outcomes can result in better outcomes later on. We need to see how reducing hypothermia, improving admission times and getting babies into a humidified environment translates into an improvement in IVH. So Talal came and gave us a talk recently, and their IVH rates are 0 to 2%, I think. Yeah. We're 10%. 10% of our babies under 1,500 grams have got IVH. 10% have got severe grade 3, grade 4 IVH. And this is the reason why we work towards this. In the end, what I'd like to say and summarize is that outcome-based resuscitation is not just about purely lung inflation and lung protection. It is about the entire package of providing care to the baby to ensure a normal thermal outcome with a lung protective ventilation strategy that admits the baby after delayed cord clamping with circulatory stability. If we get these things right and we minimally handle babies, we're then keeping them in a neuroprotected environment. The theory is that actually we should have better outcomes. It doesn't always translate, but I think if we get the basics right, then really, at some point in my career, having done it for 25 years, we should be able to achieve better outcomes for the babies we look after. Thank you very much.
Thank you so much, Dr. Alok, for this nice talk.
Shukran, Mr. Chairman. Thanks for the two speakers. We already accepted all the evidence telling us that non-invasive is the best, is the safest. But if I give you this scenario for both speakers, Sharma specifically, when we have a baby, we come in the morning, he's 26 weeks, close to be extubated, room air, backup rate 20, and the nurse should tell you, no, I'm not happy to extubate him. This baby is going to fail. So it's not our decision sometimes alone. Sometimes it's a team decision. If the team, they feel comfortable, it is too much. And if you feel that the nurse should stop you to extubate, you think, I'm the consultant, just extubate him. This baby will fail. And more important, more dangerous, if this baby gets difficulty in intubating him again, and sometimes he may die. So that's why we are really reluctant to extubate a baby to CPAP, or majority of our baby, they will continue in this low setting until they grow up a little bit. What's your opinion?
So I strongly agree. Now, when I joined the Corniche, we were very much on the cusp of saying we need to CPAP all our babies 22 to 25 weeks. And I was very much against it because of the logistics of the time that's spent, the fact that you have to move these babies over long distances, you have CPAP interface changes, and we have skill issues. You know, not every person is really comfortable intubating. I think the agreement in principle from our perspective is when we go there as a team, you assess each baby individually. And at least for the most preterm babies, at the moment we recommend IPPV intubation. We will only extubate once we're absolutely happy that the team that can manage the baby has somebody who can manage the airway in those circumstances if the baby fails. And for me, the nursing kind of, I would say, you know, if she's got anxieties about it and she said something, I think I would take that very seriously. And it's really going back to objectively evaluating whether now is the right time to do it or whether we need to postpone it. So I support that contention, yeah.
Thank you very much for this question. As always I said, this is a team approach. It's not one-man show. With the whole respect for this nurse, I will ask her why. Let me give you a scenario. If this patient, 26 weeks, on minimal ventilatory support, and the CO2, PCO2 and the blood gas 28, are you going to stop not to extubate the patient? Very low CO2, vasoconstriction in brain vessels, maybe has consequences to the brain. I will ask her why. You have blood gas, you have blood pressure, you have oxygen saturation. It's not a physician alone, but in the same time, I'll ask the nurse why. Or sometimes the respiratory therapist, they have hesitant to extubate. Go objectively. At target number one, the patient should not suffer.
My only other take on it is a simple example, human factors. So if a baby is relatively stable, my experience is 4 o'clock in the morning, we're going to hand over at about 6:30, and you decide to hand over when all the team is handing over. You have a new team who's not familiar, who doesn't have any trend analysis. So I think situations like that, you know, pragmatism must prevail. I agree, if the baby's hypocarbic or there's a concern, then we really need to objectively analyze whether we can do it safely or there's some way that we can get this baby more normocarbic. So it's a bit of both. What I would say is that if it's the team on the ground and they're not happy, then we need to be a little bit cautious about why, yeah.
Okay, thank you very much for our speaker, for Alok and Dr. Saad. My question here. My question regarding management of extremely low birth weight. I mean, they call it the micro-preemie, baby less than 25 weeker. And I think the message from here, CPAP in the delivery room is not for all. So some babies, really, they need to be intubated and stabilize them and then consider, especially the micro-preemie babies, 25, 23, 24. For the same also for the Lisa and Mist. So it's not for everybody. And I think when the paper about Lisa and Mist, everybody was excited and majority of units start using it. The problem is without training, and in the presence of absence of guidelines or unit protocol for use of Lisa and Mist, it has been abused, and I see it myself. So a baby who really needed Lisa and Mist is not used, and they used to everybody. The second thing, Lisa and Mist for bigger baby. I mean, 34 weeker who is really distressed, ultrasound showed RDS. I mean, our aim from Lisa is the duration of mechanical ventilation, BBD, but in the bigger baby, the risk is very low. So my practice for the bigger baby, I use Ensure. For the smaller baby, we may use Lisa. So what do you think, both Alok and Prof. Saad?
I think I agree with you, and I have mentioned this in my presentation. It's a team approach, need training, still clinical assessment is number one. Again, as I said during my presentation, extremely low birth weight infant, 24, 23, personally, and also even the literature. Most of them, they need intubation in delivery room, though there's some studies saying they use it because usually they are very sick.
So just a flavor of the units that are using Lisa between 22 and 24 weeks, mainly the German neonatal network. You're talking about Angela Cribbs in Cologne. Now look at their setup. The mother delivers, the baby delivers, he's in the same room, all the management takes place in that room for an extended period of time, baby is stabilized and then is moved to their neonatal unit, basically on non-invasive respiratory support without a break. So look at the ergonomics, look at the situation. We have very different ergonomic setups, and hence, again, you have to be very cautious about saying that Lisa is universally applicable between 22 and 24 weeks everywhere. The second thing to say is, if you look at the Japanese group, if you look at Iowa, they have the highest survival outcomes for babies between 22 and 24 weeks. They intubate these babies. They keep them intubated for 4 to 5 weeks. They worry about mortality from other reasons. So there are clearly different approaches to management. And I would say what is more important is deciding your unit ethos and training to that ethos. Because you will be more successful if you're able to have highly skilled individuals who can manage using your unit protocols for those babies. There will be the odd baby who is very vigorous. I have 500 grammars who do very well, and they manage on CPAP. There will also be, I would say, very mature babies who have florid RDS. And a good example that I'll give you mentioned Ensure. So the more vigorous babies, we keep Ensure for babies under 32 weeks, but over 32 weeks, these babies often really hate having a Lisa catheter being slowly given to them over 3 minutes. It's like drowning them. For me, you have to use some form of analgesic sedation in these babies. Hence, I prefer Ensure because it's an in-out with a very rapid bolus, which is given over 30 seconds. And I can't say there's any evidence for it, but I can tell you that with my skills, I've had a lot of success with it. So again, we're going to have to individualize for each baby. And I would say that do well what you're good at doing. Don't hesitate to do it.
Thank you very much for both speakers. Just allow me a question for both of you, because time permits. first for Alok, I just want to take a step back and go to what we kind of see in smaller volume centers, because I need your feedback about this. We see a lot of places that still do not use either a flow inflating bag or your simple neopuff. You still see a lot of places using the self-inflating bag, and we all know that PEEP is not being delivered. Now, the other challenge is, or something that is not recognized by many centers, that the transfer from the labor and the delivery to the NICU sometimes can be done either on a simple nasal cannula or on a face mask, where you're essentially not giving any CPAP as well. So I would like you to comment about that. And for Dr. Saad, thank you very much for the presentation. My question is about second dose missed or LISA. Now, if the baby within 6 to 12 hours requires a second dose, would you recommend that we intubate or we give a second dose, and why? And another question, I'm sorry, Dr. Saad, one more, is when we try to implement LISA or missed initially, there is a lot of worry about the risk of pulmonary hemorrhage. Although pulmonary hemorrhage is known to be reduced actually with MISA and LIST, not higher. But a lot of people, including the nursing staff, feel that even if pulmonary hemorrhage occurs as a natural consequence of RDS, that it is a more controlled environment to have the baby intubated anyway. What is your opinion about this?
So taking the first question about kind of, I would say, level 2 and level 1 units, and in particular the absence of having PEEP circuits and using self-inflating bags, I think there is good evidence that we should be transitioning onto the use of non-invasive respiratory support that delivers an element of PEEP. Now, there are self-inflating bags that are able to deliver PEEP. Can I just say that a randomized controlled trial of comparison between both the self-inflating bag with PEEP and the TP shows that it's really poorly delivered by the self-inflating bag with PEEP. It's very variable. This is a simulated model. Hence, I would say that having the ability to use a T-piece in those centers, for me, is quite essential. It needs an element of training, but can be rapidly learned. I think the other important aspect to it is the just transfer of preterm babies on face mask. If you're not able to deliver, say, TP-space resuscitation, and you have CPAP devices on your neonatal unit, you can adapt humidified CPAP delivery in the delivery suite by actually adding it to your resuscitators. We've done that, and we've basically done that with bubble CPAP, and that can provide PEEP. The challenge there is you will not be able to provide IPPV, so you still need a circuit to be able to provide IPPV. I think for me, the importance is about the equipment, but more importantly, the training around it. Having some element of delivery of effective PEEP is the most important aspect of it.
Thank you very much for the question, Dr. Talal. Maybe first question, I talk about it with the first time I started in one of the hospital, in that hospital, Lisa. I was around 4 o'clock p.m. The patient 30 weeks in between. There are days intubation. Wallah, la, it's not. I said, okay, let us give surfactant through Lisa. Nobody knows in the unit. First, number one, my colleague, the respiratory therapist, said there is no guidelines. He said, okay, I don't want, and our supervisor will, press on us. He said, okay, I don't want to be any problem between you and supervisor. In this case, please don't help me, because I don't want your supervisor to abuse you. The nurses, one of the assistant consultants, and myself. Just when you start to prepare, I see their supervisor standing there. And while we are preparing, said, Dr. Saadi, you get upset of us? Said, no. But they said, no guidelines, a patient needed. So we gave the first surfactant. Even their supervisor was observing with us. The problem is, to answer your second question. He's due for second dose of surfactant at 2 o'clock in the morning. Still, require some oxygen, but not enough to intubate. Now there is another assistant who has no experience with it. I suffer. I have to come from home, drive 25 minutes to give the second dose of surfactant. So you can use it. If you look at the literature, there is no agreement, and one really controversial, when you use a second, should you intubate for a second or not. Regarding the intravesical hemorrhage is multifactorial. We know it's going to happen. But for example, we will document that fluctuation of cerebral blood flow is one of the causes, and this is associated with intubation. Sometimes intubation, you cannot avoid it. You have to give. But sometimes, indirectly, you can avoid it. But there is multifactorial, is not should be in every patient. There is some predisposing factor. If you can work on this predisposing factor, you do your best. I think that's better. Does this answer your question, Dr. Dalal?
It was about pulmonary hemorrhage.
Oh, sorry. I thought you talk about IVH.
Pulmonary.
Pulmonary hemorrhage, in my opinion, is not avoidable. I agree with the statement. If it's going to happen, it's going to happen. Except if there is a predisposing factor like BDA and other significant BDA and not treated. This is maybe one of preventable factor. But it's going to happen. It will happen. You agree with me, Doctor?
Yes. I think for me, needing a second dose of surfactant, depending on the clinical status of the baby in Lisa, comes back to the question, were we right to have given Lisa in the first situation? Would we have considered doing a tube? And a simple example that I'll give you is I have a baby who's had no antenatal steroids at 26 weeks, who's needed extensive resuscitation in theater, but is reasonably stable. Now again, that's a baby who's very high risk, and I think a tube with surfactant would be the better of the two evils in that situation. In terms of babies who need a second dose of surfactant after Lisa, is it the RDS? Is it pulmonary hypertension? And making that assessment is quite crucial. Is it a pneumothorax? And can I just say that I've had a lot of babies who've developed subtle pneumothoraxes after Lisa. Now they still have a high FiO2 and they have a high work of breathing. And actually giving surfactant there may or may not be the treatment. It might be drainage of the pneumothorax. Lung ultrasound can help. It may, and before giving a second dose, we always do lung ultrasounds in babies, exclude a surfactant. Again, if you're kind of in a situation where this is a high FiO2, but CO2 clearance is okay, the question at this particular point is this more pulmonary hypertension than just pure RDS? So I think the clinical judgment around that becomes quite essential in those circumstances. I think a reflex kind of giving the second dose of surfactant without having made that evaluation might not treat every cause. Pulmonary hemorrhage, once the PVR is dropped, it is a high risk. Again, maintaining an effective PEEP, making sure that we keep the seal. And a simple example is sometimes the nurses have not noticed and the CPAP is off and the mask is off. And that's a big risk because your PVR is low and then there's a higher risk that this baby might have an hemorrhage in those circumstances. So no right or wrong answer, but yeah.
I think time is about to, we have one question, Dr.
Simple question. You said deliver effective beep. What is the effective beep in the delivery room and how we can monitoring? Can we do like ultrasound will help us? How we know the effective beep? Because it's really like I have people now going with start beep of 8 and 9. So, or we use 6 and 7. So what's your suggestion?
So I would start with 6. I think starting with 5 is a little bit homeopathic. I would say that really, if you're keeping the seal, an effective transition of heart rate and SpO2 over the first 2 minutes, and I will forward you George Smolger's paper because that's what it shows, that if your heart rate is coming up and achieving the 25th centile, which is usually a heart rate of 100, with saturations that are gradually improving, then actually I think your PEEP is working in a breathing baby. But if you're persistently bradycardic, then your PEEP is not working. And in those circumstances, if the baby is breathing, you might want to increment your PEEP and the FiO2. I can't give you a right answer for which, but starting with a PEEP of 9, the risks there is you might be subjecting that baby to a very high PEEP where it might not be needed, and the risks then of a pneumothorax are there. But the other aspect to it is PEEP can reduce venous return. You know, a PEEP of 9 in a baby who's 600 grams right from the start, who's trying to make pulmonary transition by effective ventilation, you might be decreasing venous return. So you might actually make pulmonary venous return, you might compromise it, and then it's persistent fetal circulation, not because you haven't inflated the lung, but because you have a high intrathoracic pressure. Less is more. You know, gentle is what we've been taught. So my advice would be start with 6, increment gradually, look at the heart rate and the saturations, and if they are coming up and the baby is breathing well, then most likely your PEEP is working. So use of ultrasound in the delivery suite has a double-edged sword in that to start off with, it might show that your lung aeration is coming through gradually. But actually, to give you that information in 2 minutes, no work has been done. So I can't recommend it at this particular stage. I know that in Mexico, they're doing work in babies over 32 weeks and 36 weeks, basically looking at their lung aeration right from birth onwards. And they've demonstrated good recruitment with demonstration of airlines. But I'm not aware of any evidence that shows that this has been used in babies under 32 weeks. So I won't recommend it.
Just, if you allow me for a small, very short question and comment for both of the speakers. Thank you for the nice talks. I was enjoying listening to you guys, both of you. I want to stress the point of making too much pressure on the face mask, because sometimes I have two twins. I will be looking after one, a small one, and the other one is doing well, crying. Suddenly he got apneic. What's going on? And you see the fellow, the staff, putting both hands on the mask, and you can see the mark of the mask on the face. Please, you don't need that pressure. You just need a little pressure till you see the knob of the PEEP. It's going up to 5 or 6 as you want. Just to make sure there is no leak. You will see, watch the knob of the PEEP. If it's reaching what you want, that's enough pressure. You don't need too much. And then I show them, just put little 2 fingers on the mask. It make good seal. For this, thank you for raising this, because it's a very common mistakes in resuscitating newborn babies, mainly preterm infants. The second of all, this hypothermia issue. We have a big problem with hypothermia in the past. Like in 2017, our hypothermia babies on admission, maybe 60%. Then we work hard to minimize it. We try to educate our nursing staff, physicians, and then went down over the years. Now we are reaching 20%, 15%, which great. Still we have some babies we cannot make their temperature 36.5, whatever we do, but still we should not lose hope. We try the thermal mattress, but unfortunately we stopped using it because there is some safety issue. Yeah. I wish we have a better one. I think to maintain the temperature, it will help also the baby to breathe. If you make him hypothermic, they will stop breathing. That means that you need to intubate them. For gentle ventilation, gentle stimulation, maintaining the temperature, the way to go. And this is very important. Also maintaining them during transportation. This is for hypothermia and the mask. For Dr. Saadi, Prof. Saadi, about the second dose of Lisa. We are starting Lisa for the last 6 years now. We start with the bigger babies, like 30-weeker, 32, 34. Just to train our staff, make sure they are comfortable with it. We start using the OG, then we start having this, the catheter, we call it Servocath, and it works very well actually. And then we sit together as a consultant group, we make a clear guidelines, clear policy and procedure, so nobody will be confused, nobody overusing or less using. So we decided to we went down actually to 26 weeks. Less than 26 weeks, we don't give Lisa, we just intubate and give surfactant and keep them ventilated for some time till they are ready to extubate. Above 26 weeks or 26 weeks and above, we can try to give Lisa and must be monitored by the consultant. We are using kaleidoscope to work very well, make it easy and clear. And we give the surfactant and keep the baby. If the baby tolerates CPAP, we are happy, and we just leave him with CPAP. If needs a second dose of surfactant because of high FiO2, increased work of breathing, no pneumothorax in the X-ray, we intubate. We don't give second dose of surfactant. This is our policy. It doesn't mean it's right or wrong, but this is what we do in our hospital. Thank you.
Thank you so much for all speaker and all consultants for this nice discussion and talk. I think time is over. We have now a break, and for prayer and lunch, we come back at 1:30. Thank you so much.